Actually, another very interesting development we have made over the last several years. This is my conflict of interest. I would like to discuss you with something which we all are serious cardiologists trying to neglect: iron deficiency. I would like to make a statement which is counterintuitive. We all have been linking presence of iron deficiency with anemia, which is not the case in heart failure, and we actually needed several years to understand this. What was the background of this concept? In fact, Prof.Piotr tested this concept whether replacement of iron would be beneficial, but we needed several years to set up this trial. Let me start by saying that iron deficiency is a very frequent comorbidity. And again, I would like to make this very clear. I would like to differentiate anemia from iron deficiency. Iron deficiency affects half of patients, regardless whether they are stable or admitted to heart failure due to heart failure decompensation. Heart failure complicated with iron deficiency is always associated with very bad functional capacity, poor quality of life, and increased mortality. And this statement, I repeated already twice, deleterious consequences of iron deficiency are irrespective of anemia. This is why it gave us a hint that correction of iron deficiency itself may well become an attractive therapeutic target. We tested this previously in one big trial, together with Stefan Anker. We are able to demonstrate that patients with heart failure and iron deficiency treated with IV iron. It's not oral iron. Oral iron doesn't work, and we can have a debate why. But at least in heart failure, we don't have evidence that it works. We have the evidence that IV iron works. And this is actually a trial called FERRACHAT, where we're able to prove that both regarding patient global assessment and New York Heart Fractional Class, it works well. Patients treated with IV iron, they do much better, and also they did very well regarding quality of life. However, several pieces of information were lacking. We needed to replicate these results. We needed to study different endpoints. We needed to study their longer follow-up, and we were not sure whether this repeated dosing is what we really want. And with the new compound, we can simply give 500 to 1,000 milligrams once every 3-4 months. And this is why we executed the trial called Prof.Piotr. We also wanted to find out the potential impact on the outcomes, which for all of us is of key importance. This is the study design of the Prof.Piotr. As you see here, was a multi-center, randomized, double-blind, placebo-controlled study. We included patients with New York Heart Class 2 and 3 with impaired ejection fraction. We ensured the diagnosis by increased BNP on NT-proBNP, and very importantly, we used very simple diagnosis of iron deficiency. Either a low ferritin level, or if normal or normalish level, then we needed also to have a very low TSAT. In other words, we can use this, we can measure this in everyday clinical scenario. I am not saying this is an optimal pathophysiologically definition, and we can debate it, but again, it works, and you will see it works at least in 2 consecutive trials. There was no low level for hemoglobin. We made sure that patients with hemoglobin over 15 were excluded. To make this iron trial blinded is not easy, because simply we have a brownish iron is in the brownish solution. So this is why we use unblinded and blind personnel. We use curtains and black syringes for the injections. We screened our patients and randomized them into 1:1 to ferric carboxymaltose, placebo, and we followed them and treated them for 52 weeks, 1 year follow-up. The primary endpoint of this trial was a change in 6-minute walking test from baseline to week 24. However, we investigated several exercise, quality of life, functional capacity related endpoints, and Very importantly, we also pre-planned to investigate the outcome-related secondary endpoints, namely hospitalization rate and death rate. And these events were adjudicated by the blinded endpoint committee. This is a patient characteristics. As you see here, we recruited slightly over 300 patients, 1-to-1 to ferric carboxymaltose placebo. They were in their late 60s, around half-half male, female, half-half class 2 and 3, impaired ejection fraction. And as you see here, patients were optimally treated. Virtually everybody was receiving ACE inhibitor, angiotensin receptor blockers, 90% beta blockers, and more than 60%, around 60% mineralocorticoid receptor antagonists. And here you see that most of these patients entered the trial having iron deficiency based on low ferritin level. This is the primary endpoint of the trial. Treatment with ferric carboxymaltose improved exercise tolerance as evidenced by increased 6-minute walking test distance in those treated with FCM by around 18 meters, and at the same time deterioration in patients with placebo group by 13 meters, which gave us a treatment effect of 33 meters at the end of 6 months follow-up period. For your perusal, that sort of a magnitude effect was only seen with cardiac resynchronization therapy. These are the secondary endpoints. Patient global assessment and NIHA functional class also improved, and as you see here, it was a consistent and sustainable effect favoring patients receiving ferric carboxymaltose. We obviously assessed 6-minute walking test throughout the whole study, and as you see here, the improvement was seen at the 24 weeks and sustained until the end of the trial. And also fatigue score, which in our study measured the perception of symptoms during the exercise testing, improved significantly favoring patients treated with ferric carboxymaltose. What about quality of life? Similarly to the results in FER-HF, we observed improvement in patients' quality of life favoring active treatment, and the results were detected early and sustained until the end of the study. Perhaps you would be mostly interested in the outcomes, because we knew that if we replete iron, it would most likely improve symptoms. We just needed to make sure that it works in a second big trial. We just, in this trial, wanted to evaluate what's going on with the outcomes. We were able to demonstrate that there was no difference in death. Keep in mind that there were only 300 patients in the study. However, what was very important, we were able to demonstrate that the hospitalization due to heart failure worsening, the hazard ratio was 0.4. It means 60% reduction in the risk of heart failure hospitalization. And if we calculated something which is extremely important, recurrent hospitalizations due to heart failure worsening, the hazard ratio was 0.30, giving us the hint that the reduction was by 70%. This is depicted here, and as you see, the Kaplan-Meier curves depicting the hospitalization rate started to diverge early, and this effect was seen in a bigger scale at the end of the follow-up. In other words, at the end of 1-year follow-up. Importantly, the subgroup analysis ensured us that this treatment works across the whole spectrum of heart failure patients. We pre-planned analysis in several subgroups, and as you see here, it worked in all pre-planned subgroups. Most importantly, again, including patients with low hemoglobin and normal hemoglobin, again showing the same data we saw in the FER-HF trial. That patients with hemoglobin over 12 also benefited from IV iron once they had the evidence of iron deficiency. Obviously, you may well be aware that with this treatment, everyone who started giving iron several years ago was a little bit not convinced and not certain whether this is safe. The new compound is safe, and as you see here, regarding the adverse events, also including serious adverse events, there was no serious concern and there was no safety signal regarding the ferric carboxymaltose group. Importantly, as a conclusion, we stated that in symptomatic heart failure patients who had iron deficiency, therapy with IV ferric carboxymaltose over 1 year resulted in sustainable improvement in functional capacity, symptoms and quality of life, and more importantly, it may reduce the risk of heart failure hospitalization due to heart failure worsening. Only recently, we put several studies investigating IV iron therapy together. We focus on randomized controlled trials. We found 6 papers, 6 studies. We put them together, and just for your perusal, if we took into consideration functional improvement, there is a very clear picture that there is improvement in functional capacity. And also, if we looked at the studies investigating or reporting the outcomes, we had more or less the same results, 70% reduction in the risk of heart failure hospitalization. Obviously, we will continue. We will study now patients with heart failure and preserved ejection fractions. Ongoing trial with heart failure patients investigating the effect of IV iron on peak oxygen consumption. Several meta-analyses planned, and I truly believe that we reached the stage to plan a mortality and morbidity trial to finally answer the question whether this treatment, on the top of functional capacity, quality of life improvement, also reduces the risk of heart endpoint. Thank you for your attention.
Thank you, Dr. Ponikowski. I have 2 small questions. How do you estimate the frequency of iron deficiency in the general population of heart failure patients? The second question, as chairman of the committee for heart failure guidelines, how are you going to look at iron depletion in patients with heart failure?
First of all, addressing second question, I have conflict of interest. So in this area, I would be out, and I leave this for the other members of the committee to judge whether the evidence is strong enough to put it and how to phrase it. I declare conflict of interest, and I, by all means, would not be voting or even trying to touch this subject, but from my perspective, as I said, declaring conflict of interest, at least regarding the functional improvement, at least regarding the quality of life, and which really matters. There is very convincing evidence that it works very well. Regarding the prevalence, we used a definition which we used in the FERRHF and confirm, and it looks like so low ferritin level, and if ferritin between 100 to 300, also low TSAT, and we estimate that around 40 to 50% of patients are affected with iron deficiency. In the recent paper with my colleague Eva Jankowska, we did slightly more sophisticated approach, and we used hepcidin and soluble transferrin receptors. This is difficult in clinical practice. Hepcidin measure and assessment is tough. Also soluble receptor, transferrin receptor, but we had more or less the same kind of a measure. So we believe that 40 to 50% of patients with heart failure tended to have a concomitant iron deficiency.
Thank you, Dr. Piotr. And now we'll, I think I'm sorry, sir, but we have no time, and we have a break for 25 minutes and get back to continue the session. Thank you.